we will just continue our discussion about pediatric anesthesia from where we stopped. Any question before we start? Anyone wants to ask any question? Any question before we start? Can all of you hear me?
Yes, we can hear you.
Yes. So actually, we just started with the general consideration, and actually, we just try to have problem-based learning. Like, what is the change? What is the problem? What is the effect? And how to manage it. That's what actually I just tried. So, and actually, if you use this way in learning any topic, it becomes very easy because whatever disease, it may be disease, it may be a physiological change. Okay. So first of all, you have to chalk out what is the, just pardon me. Just please, just a second. Actually, I'm on call. Just let me take the call. Just hold on, please. Yes. I was saying that whenever you are trying to read any topic, you just, if you think that there is some change, okay? So there is some change which happens, okay? And there is some effect. And then you have to divide if its effect on different steps of anesthesia. For example, steps of anesthesia and systemic effects. Okay. And then after that, you will have to modify your technique of anesthesia. Okay. So if you just try to whatever you are reading, whether this is a physiological change like any pediatrics or elderly, okay, or smoker, or for example, obese, okay, neonate, pregnant, or any common disease like hypertension, diabetes mellitus, opioid addict, okay, alcoholic, okay, and then you can make this list more. So just try to fit it. What is the change? I'm writing again: change, effect, and how to manage. Okay. So just try to fill any topic you are reading in this gap. Okay. So I will have you faced it is status epilepticus? What is status epilepticus?
Status epilepticus can be defined as the continuous intermittent or continuous state of the fits which is not responding to the management at least for 30 minutes, if I'm not
Or
wrong.
repeated or without any gap. Okay, without any significant gap. So if we just because this is another emergency which they can ask, status epilepticus management in kids. So what will be different? Just a second.
I think so. Duration is same for both adult and pediatric population.
Just a second, please. Okay. So actually, if you are managing status epilepticus management in pediatric population, first of all, you can have a look on the reversible causes in addition to airway, breathing, and circulation, which is there, and you have to prevent the fall. We have to prevent the tongue bite. Okay, things like that. And you will see whether there is IV line or there is no IV line. If there is IV line, you will you will start with midazolam or lorazepam. Okay. And if there is no IV line, you will go for either buccal, intranasal, or even like this one, rectally. Okay, you can use some rectal route as well. Okay, so if there is still it's fitting, no, if no, then you have to keep the patient stabilized and you have to monitor the patient. Okay, and here you will go towards the reversible causes. Okay. If it is still going on, then you will go to second stage. So maybe you are giving some this one, I think, um, I forgot the name by which it is coming. Capra. Okay. Usually levitriastem, because usually we are not pronunciating it. It's a different pronunciate. So usually we are labeling it as Capra. It's a trade name actually. So you will go for phenytoin, second stage, and then still it's going on. Then the phenobarbital. Actually, this is the third stage. It's phenytoin. This phenobarbital. Okay. In addition to that, you will be managing the airway, breathing, circulation. You can put the patient on mechanical ventilation. Okay. This is how you will be proceeding. Okay. Actually, I was not finding from the place where I did read. It is written in a slightly different way. You will find in the neuro. I will just try to show you. So another thing which I wanted to discuss is can you highlight who wants to speak about fetal circulation? Who can speak? Zishan? Yes, Dr. Jackson. Yes. Fetal circulation. Oh, who wants to speak out?
Sir, you can say fetal
Yes.
circulation is different from adults. Fetal circulation starts from the umbilical artery.
Mm-hmm.
The blood comes from the placenta. The umbilical artery goes through the
Umbilical artery or
liver
umbilical vein?
vein.
If you are
Sorry, yeah,
starting from placenta side, from the mother to fetus, so it is umbilical vein. Okay,
vein. Yeah. So the umbilical
umbilical
vein
vein.
takes blood. It passes through the liver.
Mhm.
Uh, it is called, I think, ductus venosus,
So
where
it is
it passes
bypass and it enters to the vena cava. Okay,
through the vena cava. Yes.
in vena vena.
From
That's
the
there. That's here it goes. Like it is coming
yes, sir.
from umbilical vein, and they are showing it as red. So maximum saturation will be
Arterial
here.
blood saturation will
Okay.
be
So
yes.
then it is bypassing the liver and it is going through inferior vena cava. It is reaching the
Right. It,
uh, right atrium. Okay. So what is different about it is that it will be
sir,
going from the
from the
foramen
right.
vein,
Yes, sir. From the foramen
foramen
vein
vein,
to
it
the
will
left
go
atrium.
from right atrium to
Left atrium,
left atrium, and then left atrium to left ventricle,
coronary
and that's
ventricle,
left
and then
ventricle pull out, and then there will be a bad boy which is coming, that is ductus arteriosus. Okay, so why it is bad boy? Because it is coming from the upper half of the body, the superior vena cava is coming. Okay, and this is very blue blood, very like it's a dirty blood. Okay, so what happens that here, before this bad boy is coming, the main arterial supply to the body will come out. Okay, the main arterial supply, I think it is not shown here, but the thyrocervical trunk will come out, and the main arterial supply to the upper half of the body will go out. Okay. So now after that, the bad boy will come, that is ductus arteriosus, and with poorly oxygenated blood will mix here. Okay. How it will be mixing? That it will be coming from the right atrium, and it is not going towards the foramina veil. It is going from right atrium to right ventricle. Okay. And then from right ventricle through the interventricular septum, it is it is going towards the pulmonary artery, but because there is too much high resistance there, so it is going from pulmonary artery through ductus arteriosus as a bad boy, and it enters in the aorta. Okay. Because the door is closed, there is that area is closed, the lungs, it's full of fluid, so now no blood is going towards the lungs, so it is bypassed from the pulmonary artery through the ductus arteriosus to enter in the aorta. Okay. So when it is so that is the concept of preductal and postductal. So preductal, before the entrance of the bad boy, the good blood is bypassed and going towards the upper half of the body, and that's why if you want to look in the baby is having some this persistent fetal circulation, you have to monitor the saturation in the right radial artery, which will be preductal. Okay, which will be preductal. So after ductus arteriosus, that is postductal, and that will be relatively less oxygenated blood, and that is going towards the lower half of the body through this descending aorta, and later on it is going back from through umbilical arteries back to placenta. Okay, so that is the concept of fetal circulation. That is important when you are thinking about what is ductus arteriosus, what is patent ductal artery. Usually when the first breath occurs, when the first breath occurs, there is a decrease in pulmonary vascular resistance, and actually blood starts going, PO2 increase, and blood starts going towards the lungs. Okay. So gradually this ductus arteriosus closes. It can remain up to few hours, or if there is some problem, it can remain for some time. This one sometimes in some congenital heart diseases, the baby is surviving through this duct because there is complex congenital heart disease. So in those patients, actually we have to maintain the duct. They have duct dependent circulation. So in these patients, they are receiving actually prostaglandins to maintain this PDA. Okay. So that is an exception. You just understand this concept. And another concept which is very important in cyanotic heart disease, that you have to balance, or you have to maintain the balance between pulmonary vascular resistance and systemic vascular resistance. Because any factor which is increasing the pulmonary vascular resistance, so blood will go towards from right to left. So that will be blue blood going to the red blood. So there is cyanosis. Okay. So that is what is called as that spells which occur in tetralogy of Fallot. Okay. And for that thing, you need to increase the pulmonary vascular resistance. So the baby learn to have squatting. Okay. So whenever there is squatting, the pulmonary vascular resistance is increased. Okay. And sorry, systemic vascular resistance is increased, and this shunt is reversed. Right to left becomes left to right. Okay. So similarly, if you want to treat it, you can give some fluid, and you can give some phenylephrine. Okay. Phenylephrine, which will increase the SVR, and again it will reverse the shunt. Okay. So this is another thing. And another important thing is that if like if you want to close it, there is indomethacin. In some conditions, it is given to close PDA. Okay, to close PDA. So this is something. Another thing is that you have to avoid the factors which increase pulmonary vascular resistance. Okay, so that is decrease CO2, decrease O2, increased CO2, this stress, okay, pain, like any factor which increase pulmonary, increase pulmonary pressures. Okay, so it will result in right to left shunt. Okay, so another question to who will answer? Memuna, what will be effect in right to left shunt in IV induction and inhalational induction? Yes,
In right to left shunt,
yes.
there will be rapid
Rapid,
inhalational induction.
rapid inhalational induction. How? What is MAC?
Yes, okay. I'm wrong. Rapid IV induction. Yes.
Rapid IV induction and
Yes,
slower
delayed
inhalational.
inhalational induction and
And it
vice
will be
versa.
less effect on desflurane than
Yes.
isoflurane or halothane. Why?
Isoflurane.
Why?
Because of blood gas coefficient
Yes, blood gas partition
0.42.
coefficient, because
That is
desflurane is already least soluble. Okay, so it does not have
yes.
much effect as compared to isoflurane or halothane, but it will be slowed down. Okay, in right to left shunt,
Yes.
there is slowing of inhalational induction and fast IV induction. And what about left to right shunt?
So it will be vice versa.
Yes. Any improvement in the answer? Zishan, would
In
you like to add on? Or anyone wants to add on, please?
Basically, in right to left shunt, the insoluble anesthetics are more affected, and the speed of induction for inhalational will be decreased in right to left shunt. And vice versa means that in left to right shunt, the speed of induction of IV induction will be decreased.
Okay. So this is, so another thing is that what happens in anemia? Induction. There is increase cardiac output. So IV induction will be faster or slower?
sir, in anemia,
Yes.
High cardiac output state.
it is like
Sepsis.
It should
hyperdynamic circuit. So it
Sorry.
um, in the in anemia,
so it
Yes.
should
I
be
have to
increased
tell first.
cardiac output states.
So IV induction should be fast or slow?
It should be faster.
Fast. So why are you so confused? If the cardiac output is increased, it will be fast.
Fast.
Okay.
Yes, sir, in
But
all hyperdynamic circulations. Yes.
hyperthyroidism, there is no clinical significant effect
On MAC.
on MAC. Okay. So and what about inhalational induction in anemia? It will be slower because of high cardiac output.
Right.
What about MAC in anemia? Because speed is something else.
Yes, sir. MAC won't be affected.
No, no effect.
Speed and MAC. So so actually, maybe I'm a little bit confused in myself. Just confirm it. But you should be knowing what is the effect of right to in different physiological condition. Just learn what is the effect. We will discuss it at some other time because I just got a little bit strange. I'm no. So next topic we will be considering is some congenital anomalies. Okay, so what about Down syndrome? Who will tell?
There a child with Down syndrome.
Yes. What will be the
There are concerns in a Down syndrome patient. Um, so there are mostly anatomical and physiological differences. Where if we start from the top, like for the airway, there will be small mouth, and skull is occiput is large, I think.
that is
Eyes,
normal.
then
That is
the
for normal. Small mouth,
right
small trachea,
small trachea. Yes, sir. So,
small
but the tongue
endotracheal
is
tube.
large, macroglossia. There will be macroglossia and micrognathia, and
Yes.
the palate is also, I
Atlantoaxial
think,
subluxation.
plantar subluxation. And these
Okay.
children tend to have OSA also,
Yes.
and
OSA.
broad neck. They have large neck.
No, not large neck. No, large neck is not it. Try to
Short
highlight
neck.
that you don't
Short.
need to
Short.
tell 10 things. You tell small things, less
Sir,
number, but be very specific. Okay.
sir.
So you can say that in addition to airway changes which are there in any baby, additionally they have a risk of atlantoaxial subluxation. This will make your life easier. Okay, they have relatively small trachea, narrow diameter, so you have to use smaller endotracheal tubes. Okay, and they have chances of
Right.
OSA, so that will become easier for you to tell. Okay, so
Yes, sir.
when there is atlantoaxial subluxation, then it's difficult for you to make to extend the neck. Okay, which is already difficult
Yes,
in
sir.
babies. So now you are limited even further. So you will be
Yes, sir.
anticipating difficult airway. Okay,
Yes, sir.
then
Then they
cardiac.
tend to have cardiac anomalies also.
Yes, ASD, VSD,
Uh,
AVSD,
yes, sir.
endocardial cushion defects.
Bundle cushion defects.
Okay,
And
ABA.
yes, sir.
Okay.
And they tend to have epilepsy also.
Epilepsy, as I have written
GERD.
here, epilepsy, they have communication problems, they are more incidence of hypothyroidism. Okay,
Yes,
so and rest of the thing you will say all the altered physiological, pharmacological, and anatomical considerations in any pediatric patient. In addition to that, these three, four, five problems. Okay. So they have some increased secretions. They have more chances of respiratory tract infections. Okay, things like that. Okay, anything we missed? Anyone want to add? Because actually, I'm not opening the source, so just to save the time because I might need to run away if they call me again. Okay, so we discussed pyloric stenosis before. So another tetralogy of Fallet, they will not usually ask, but at least you should be knowing the concept of right to left shunt, and they can ask you what are the four changes. So what is even I forget always. There is can anyone tell? There is aorta, pulmonary artery overarching aorta. What else?
There is
The
VSD,
VSD.
VSD
VSD
and
overriding of
overriding
aorta
of
over
aorta.
VSD. Over
VST,
VST.
and there is right ventricular outflow obstruction.
Yes.
Okay,
Fourth is
that's why.
overriding of your
So
acha.
that's why they use propanolol to decrease this spasm, infundibulary muscle spasm. Okay. Okay. So you just recall it. I may be wrong because usually they are not asking in your exam, but you should have a concept and you should be knowing how to control the dead spell, as I told you. Phenylephrine, fluid, avoidance of the factors which increase pulmonary vascular resistance or decrease SVR. Okay. PVR versus SVR. You have to maintain the balance. You don't need to say that I have to increase the SVR. You use the word, we have to maintain the balance. Okay. So next, simple, I'm asking that, then we will discuss TOF and congenital diaphragmatic hernia. So abdominal wall defects, Gastric Ices and Omphalocele. Remember one thing I am telling you again and again, whenever they ask this question, that's why the things which we have discussed in the morning have made our life very simple. Okay. Because now whenever they are asking you any pediatric problem, you know that there are logistic problem, equipment problem, IV line problem, uh, hypothermia problem, uh, and things like that. So they are common in any pediatric patient. You have to calculate the fluid, you have to calculate the medication doses, you have to make diluted doses, you might need to have enzylysis and things like that. I don't need to repeat again and again. Okay. Well, I think few things we left. We will discuss, like for example, role of brown fat and consent issues. Okay. You need to have a consent from the parents, and you have to rule out congenital heart diseases. Okay. Brown fat, they don't have the shivering mechanism. Okay. So they are dependent on the metabolism of brown fat. So they can ask you where is the location of brown fat? Interscapular region, long chest. I don't remember the exact location. You just have a look, because this is academic stuff. I forget. Brown fat, you should be knowing what's the location of brown fat.
In the ribs and the sternum.
Yes, interscapular region, ribs, sternum. Okay. So you should be knowing this thing, that they don't have shivering mechanism. That's why they tend to develop hypothermia. Then consent issue, you need to have a consent, and because this consent issue is mainly asked in the international exam. In Pakistan Indian exam, I don't think so they are over stressing on consent issue, but there are actually consent there is age limit, and if there is, because they also have single parents, so they have complex problems. Even sometimes they are brought by the grandfathers. So if you are appearing in the international exams, you might need to have some extra than the common, but you should be thinking about consent issue. Congenital heart disease, usually there will be history of cyanosis. Okay. And whenever there is one congenital anomaly, you have to rule out other congenital anomalies. Okay. So you can ask about history of cyanotic spells, feeding. Okay. And any other congenital. So remember, as a journal principle, remember one thing: whenever you are asking history, these are the things which are very important. And another thing is the developmental milestones. Okay. Always use this word, developmental milestones. So like
Repeated
the babe.
chest infection as well.
Yes, just in fact, yes, we will discuss about what is the significance of RTI. So let's discuss these things as well. Not every baby will have chances of RTI. There are certain conditions in which there will be more chances. Like for example, one of the disease which is common is cerebral palsy. Okay. So in cerebral palsy, there was recurrent chest infections because of stasis. But RTI, upper RTI is more common, which is, so when will you postpone the case on the basis of RTI? Is it only sneezing?
No,
No. Is it only cough? No.
no,
Secretions? No.
yes, no,
No. Purulent. Purulent
yes, rural and product.
sputum. Yes. Okay. bronchospasm,
Active wheeze, yeah, bronchospasm.
yes. Fever,
Yes.
yes. Okay. So you have to
Associated
rule out, and you
distress.
have to, if you have to rule out, you have to do rule postpone to 4 to 6 weeks. Okay. Or at least 4 weeks. Okay. And another thing, if you have to proceed, what will you be doing? You are expecting exaggerated airway.
Hyper responsive airway.
Yes, hyper-responsive. So what will you be saying? I will be expecting bronchospasm,
Bronchospasm and laryngospasm.
laryngospasm. Okay. And post-operative airway obstruction. Okay. So if you are doing it, any case which you, in which you have to, so you will be saying that maybe you can use LMA, maybe you can blunt the blunt stress response. Okay. And then you can have awake extubation. So these are the things which you can say. Okay. You can use some anti-swallowgog to reduce the secretions. Okay. You can use lidocaine to have membrane stabilizing effect. Okay. So these are the things which you can say about it. So I think if anything else I just recall, I will tell you, but I think these were the things which are general things, Okay. So okay, coming back to gastroschisis. Okay. So gastroschisis versus omphalocele. So what is the biggest difference between these two things? Gastroschisis is the only isolated,
Yes, no associated with other congenital
associated,
anomalies.
okay, anomaly. Okay,
And
which is
no
usually midline. Gastroschisis or omphalocele?
omphalocele.
Omphalocele.
Midline is omphalocele. Which is more dangerous?
Gastroschisis.
I'm sorry?
Gastroschisis.
Gastroschisis. Okay, what is the reason for it? Dangerous with regards to, dangerous with
Infection.
regard to injury, okay, and
Injury, fluid
dehydration.
loss, dehydration. Yes.
Why?
Because there is no peritoneal covering.
Yes. Okay. So this
More
is
exposed surface area.
more exposed surface area. There is no covering. Okay. So gastroschisis need to be operated earlier than omphalocele. Omphalocele is midline, but usually with the sac. Okay. So rest of the things, believe me, are the same. And again, the same principle. Same principles you have to optimize. You have to evaluate, optimize, multidisciplinary team. Okay. Rule out other congenital anomalies. Maybe you need to optimize the fluid electrolyte. Evaluation we have discussed in the morning, that you will be evaluating on the basis of history, examination, and maybe you are doing some investigation. Okay. So this we had done in the morning. So this is only this thing you need to know if you are reading, especially about omphalocele or gastroschisis. Rest of the things will be the same concerns of airway, cardiac, fixed cardiac output, and again the same. If so, what is the key? That if you make a list of the common things and just cram it, make it your second nature, because pediatric will be asked in any exam. Okay. So just make a habit or make a notes about the common things which you have to tell. The first sentence should be altered physiological, pharmacological, and anatomical consideration in this age group, warranting modification, care, caution in airway, in maintaining the fluid, in maintaining the and doing the monitoring, etc., etc. You can make a line, a statement at your ease. But because in table viva, you only have usually in any exam, whatever exam you are appearing, usually there is 4 to 5 minutes for one scenario. So people unfortunately don't understand. They are saying, sir, we will be taking the history. You are wasting seconds. It is counting and then you are lost. You miss important things. Okay. So now comes to the next congenital anomaly, which is tracheoesophageal fistula. Okay. Before we go to tracheoesophageal fistula and congenital diaphragmatic hernia, what is vector, vectral, and veter? Who will tell?
Vertebral
Vertebral.
anomaly,
Vectral we know.
tracheal
One person,
esophageal
please.
fistula.
One person. Yes, yes. Please continue. Dr. Ishrat, you are talking.
Vertebral anomaly, tracheal esophageal fistula, and
Okay. E
and,
for
and there is one
esophageal.
more thing.
Esophageal.
Fistula,
No, esophageal atresia.
atresia.
Okay. And L for
Limb
Uh,
limb,
deformity.
limb deformities. Okay.
Sir. But some things were left, like A for anal atresia,
Anal
C for
atresia. C for cardiac, I have written here.
cardiac anomalies.
Actually,
Yes, sir.
cardiac. A for what about R? Renal.
Renal
Okay.
agenesis.
Renal agenesis. Okay. And A for anal
No, sir, there is no A.
deformities. There is no A?
Yes, sir. The initial A. Yes, sir. The
Yes, yes,
VACTERL.
yes. Yes. So just to repeat, vertebral, anal, cardiac, tracheoesophageal, esophageal atresia, renal dysplasia, and limb aplasia. Okay. Okay. So what is the most common type of TOF? Don't tell me the number. Tell me the type, because always you are worried about the number.
Type
C.
C,
No,
which
wrong.
is
Wrong. Because maybe in different books you
Which
will
there is,
find. I know
sir, in
the
which there is
typical.
the distal fistula.
Yes. Sorry.
In which there is the distal fistula.
Proximal
Proximal
atresia
atresia and distal fistula.
with distal.
tracheoesophageal fistula.
Okay. So this is the most common. They will not fail you by number. If you tell them this thing, I guarantee you they will pass you. Okay. Because I remember when I was studying, the worst time I wasted on this thing. And after 10 years, now I salute myself and to the people who used to tell that you have to know the type, but they don't tell what is the easier way to do it. Okay. So this is one thing. Then another thing, another question is, the second answer is that, is it medical emergency or surgical emergency? So it is medical emergency. Okay. What will you be doing? Again, the word evaluation will come. You will be evaluating by ruling out other anomalies. Okay. Then ruling out the dehydration, because this patient is not taking any. What is the usual presentation? They will write it in majority of the exam. They will use that thing. They will be saying there is regurgitation.
Regurgitation and ruling.
Yes, ruling. And when they
coiling
try
up
to
of
pass,
NG.
NG failure.
Yes.
Failure is not passed. Okay. Then coughing on feeding. Okay.
And choking on.
Choking, sorry, choking on feeding. Okay. So then what you have to do, you will put an NG, your approach will be ABC. You will be making sure patient is, because if the patient is desaturating, you have to intubate the patient. Otherwise, usually you will be starting for the word airway breathing. I will make sure patient airway is patent. I will put the oxygen. I will just take IV lines. I will put NG and do aspiration, and then you will be optimizing with the normal things, CBC and electrolytes and ABGs. Okay. And then you what else? Investigation, see, just chest X-ray, ECG versus echo. Okay. Usually More than ECG is echo. Echo is usually done to rule out if there is some history, or they have to rule out if there is time permitting. Then what else?
Ultrasound, rule out
Ultrasound, like you
immunogenesis.
actually, when you, because you see, again I tell you, if you use the word correctly and you said if they want to ask you further question, they will ask you. Otherwise you need to only, if you say that we will be discussing with the neonatologist, okay, and intensivist, neonatal intensivist, so to investigate properly. So in this word, you are actually telling that what you are doing, because actually anesthetist is not doing these things. Anesthetist is the, you can say, backbone, who is maintaining everything, and he should be knowing everything, but actually he is not the primary physician. So primary physician will be a pediatrician or neonatologist. Okay, so you will be optimizing the patient, and then the most important thing, which is different, a little bit different in addition to other things, that how will you induce the patient. Okay, inhalational versus rapid sequence induction, ventilation versus spontaneous ventilation. What will you do? How will you
RSI is not needed. And
okay,
IV and
you know, Zishan, just
induction
because
can
it's
be done.
for you it is
Sir,
mandatory, because I always point out to everyone that please don't use closed-ended
yes,
sentences. Like you use the word RSI is, what did you say? RSI is not?
not mandatory.
No, now you have changed the statement. Okay, so now you understand. Don't use close-ended. Be like bloody politicians.
Okay.
Okay, so that you are able to change or modify your statement. You
Yes.
can say that there is problem. It's a tricky situation. There are problems in the inhalational induction as well as in rapid sequence induction. But what are the basic principles? Basic principle is that it is better to keep the spontaneous ventilation. What will happen if you do the mechanical ventilation? What will be
Positive
happening?
ventilation.
What will be the problem? What would, when if you do
There,
IVPV, what will happen?
gastric insufflation
Gastric insufflation.
or
So FRC
and
will be reduced further.
ineffective further. Yes, risk of
Okay,
aspiration
you
will
are
increase,
filling.
and
Aspiration is not a problem because there is a open problem. Okay, so of course you are saying that there will be more risk of aspiration, but actually the problem is this series, you will not be able to oxygenate the patient.
further oxygenate.
Okay, so the better way is that to keep the patient on spontaneous ventilation. Be ready for all the problems. You might need to do the suctioning. Okay, and it is better to keep spontaneous ventilation. Then you will be doing the laryngoscopy and you pass the tube. There are different techniques, but the one way will be that you will push the tube and try to
Distal
have
to the
endobronchial. Okay,
The bronchial.
then you will see that it is
Thanks.
only on the one side. Then you will gradually withdraw. Keep on doing the auscultation. Okay, then what will be happening? And you will better to have two person. One is auscultating the stomach and one is auscultating the sides, or one person can do the same thing. Then you will be listening the gurgling sound in the stomach.
Stomach.
So you will be seeing that now you are proximal to the fistula. You will
Yes.
push it back again. Then the gurgling sound will go back. Okay. So now again repeat.
Gurgling will disappear and bilateral
Endobronchial,
can be heard.
pulling out, gurgling, pushing back a little bit. And you will fix it, mark it, and the most important thing will be a fixation of endo. You know, this is also make in the list of the things which is journal. Always fix the endotracheal tube very nicely. Okay. So this is another thing. Okay, what else? Nothing else. Believe me that people are afraid of tracheoesophageal fistula. Just tell me how easy is it to explain. They will not ask you anything else, believe me. Or if you know the general things, actually the main 70 or 80% are the common things. The patient will be in post-op HDU, sorry, NICU. Okay. Then another thing is that what about extubating versus keeping mechanical ventilation? Which is better?
Mechanical ventilation.
No, my dear. No. There is a anastomosis.
Yes, it can leak.
Just a second, please. I think. Assalamu alaikum. Yes, sorry, actually, I just received a call. Okay. So where were we? Okay. So, Mamuna, it is better to extubate the patient. Okay.
Yes, sir.
It is better to extubate the patient rather than keeping, unless, yes, of course, you are not saying that I will definitely extubate. You will say that we will, at the end of the surgery, we will discuss with the surgeon. And if there is no other problem, it is better to extubate. Okay. Or for example, even if you want to keep the patient, you can keep the patient on spontaneous ventilation or pressure control ventilation. Okay. Like spontaneous ventilation will have a lot of problems, but if you are need to keep the patient ventilated, make sure you are not over creating too much airway pressures. Okay. So this is the most important thing in this patient. Other than that, all the normal which we discussed. If you want to take arterial line, and if it is better to take right radial artery. If you want to give fluids, we have discussed about the fluid management. What else? Urine output you will be maintaining. You will be keeping the patient warm and the common things. Okay.
With neonatologist, if there is needed pre-operative, if there is any need to have pre-operative gastrostomy.
Yes,
It is
this
also
is what you
something
see.
that
I missed. Gastrostomy, what will be the advantage?
it will
Reading the
increase effort.
But the problem is that how can they do it in local? Again, it
No,
might need anesthesia. Okay. So again, this is a good point that maybe they are not doing the surgery. They are only doing the gastrostomy just to relieve the pressure and let the patient optimized. Okay. Because this patient, remember one thing, this patient may be premature. So there may be concerns related to prematurity. They will try to mature the lungs. In premature baby, there will be increased what do you say, persistent pulmonary hypertension. Okay. So these patients are at risk of barotrauma. Okay. So regarding this premature, you should be knowing about the role of surfactant, your role of
I think so. I cannot
prostaglandins.
see the screen. Maybe there is some interruption with sharing, screen sharing.
Oh, okay, just a second. Oh, I'm sorry. I stopped the air screen sharing. Just a second. Okay, so gastrostomy in premature baby, there is chances of persistent pulmonary hypertension. They are at risk of barotrauma. You should be knowing about the role of surfactant. You should be knowing about the role of prostaglandins. Okay. Similarly, these gastrostomy procedures is also being done for cerebral palsy. Okay. So actually cerebral palsy, they have either spastic or paralytic lesions. Okay, either they have weakness or there is spasm. In either cases, these patients all have risk of aspiration. They have excessive secretions. They have repeated chest infection. These patients actually have repeated chest infections. Okay, and is there something dangerous about cerebral palsy? It may be associated with some neuromuscular diseases. Am I right?
Yes, sir.
So it may be associated with some muscular dystrophies. Okay.
Chances of malignant hypertension also.
Malignant hyperthermia, if it is like Duchenne muscular dystrophy or things like that. So you should be, because it's a wide array of diseases, cerebral palsy. Okay. So congenital diaphragmatic hernia. What will be the pearls? Again, it's a medical emergency. Okay. Medical emergency for this patient specifically, what will be the things? You need to have the maturation of the lungs. Why there is problem in the maturation of lungs? Because these patients, they have, how they are diagnosed? They have what you say, the abdomen is, what is the word for it? Scaphoid abdomen.
Scaphoid abdomen.
Scaphoid abdomen.
Yes.
Okay, and when they do the
Hypoplastic
chest
lung.
X-ray, the intestines are in the lungs. Okay. And in this patient, they have, when they do the echo, they may be associated lesions, and there will be pulmonary hypertension. Pulmonary hypertension and immature lungs. Immature lungs, alveoli and you say lung. So there will be again the same problem, increased airway pressures. Okay. So this patient might need to receive surfactant. Okay. And it is better for these patients to be optimized. If this management fail, maybe this patient needs ECMO. Okay. So because sometimes it is very difficult to ventilate the patient. Okay.
And usually it is required to ventilate pre-operatively.
Yeah. What is ECMO?
Extracorporeal membrane oxygen.
Extracorporeal membrane oxygenation. So it is related, just like bypass. Okay. But here they are doing only the oxygenation. Okay. So this patient might need what inotrope medication this patient might be using? Can anyone tell?
Phenylephrine.
No. Inotrope. Is phenylephrine inotrope?
No, sorry.
It's milrinone to support right heart. Okay.
Sorry, the exact word is inodilators.
Inodilators. So the big boss of pediatric anesthesia has joined us. We are
sorry, you are the big boss.
Very happy to have you on board. It's a very surprising moment for me that you joined finally. Okay. I think you got NOC from that person. That's why you are coming here now. Anyways,
You know better.
No problem. Just I will have to tell, Jamil is my very fast friend and actually my study partner. He has done all the exams and now for fun, he is doing FCPS also. Because before that, he has passed all the international exams. Okay. So anyways, so inodilator, what is the issues with milrinone? So milrinone cause vasodilatation. Okay. So it can reduce the blood pressure. So when especially, but it is a drug of choice for right ventricular failure. Okay. So in these patients, you might need to have this thing. And another thing which is using is sildenafil. Okay. So which is also
And for,
pros-
yeah, it also vasodilator. And
phosphodiesterase.
for short term, we can use nitric oxide with 10 to 20
Yes,
ppm.
nitric oxide. It is not nitrous oxide, okay? It is nitric oxide. Nitric oxide, it is pulmonary vasodilator, okay? And how they are using it, just for your information knowledge, they are using it with the circuit, okay? And it is, they are using it in ppm. Okay.
Parts per million means very little, the flow. It's look like 100 to 250 ml per minute, and
Okay.
it's protected in the breathing circuit to just decrease the
Pulmonary vascular resistance, okay? So nitric oxide, few more words about nitric oxide. That nitric oxide, they are using it as a last resort, even in ARDS, okay? They are using it for diagnostic cardiac cath, okay? In these patients with
developed Eisenmenger syndrome or not? Yes,
complex congenital
reversible
heart disease. Okay, the actually Eisenmenger, I forgot to mention when we were discussing the fetal circulation. Maimuna, what is Eisenmenger phenomena?
Sorry, sir, your voice is very distorted. I cannot hear.
What is
properly.
Eisenmenger? What is Eisenmenger phenomena?
Eisenmenger phenomena is the conversion of reversal of shunt from
Reversal
left to
of
right.
left to right, okay? To
Yeah.
right to left.
Right to left.
Okay, so it happens actually. Eisenmenger phenomena occurs similar to Eisenmenger phenomena occurs in minority of congenital heart disease, but Eisenmenger phenomena, as I told you, as actually I use the other word, that patent duct persistent duct circulation is needed in some conditions. So actually in these conditions, this Eisenmenger phenomena is the survival of the baby till the time they don't get operated. But this is beyond the domain of your exam. Nobody will be expecting you to know all this stuff. Okay. So in congenital diaphragmatic hernia, again, the same things which we have discussed. It's a medical emergency. You have to optimize the patient. You have to rule out other problems. You have to maintain the oxygenation. You might need to have ECMO. And the only question which they are asking you is how to intubate, for example. Usually these patients are optimized in ICU. And again, the same principle, don't do positive pressure ventilation. Okay, with caution. If you need to do, you have to be very cautious. You have to do it very softly without too much pressure. Okay. And they ask a question that suddenly the patient have hypoxia, develop further worsening hypoxia, and there is no air movement. So what has happened? So it is pneumothorax. Okay.
Yeah, most of the time, sorry, sir, if I can just elaborate the mechanism of pneumothorax. Definitely, there is which side there is diaphragmatic hernia, that lungs now does not expand, and the lungs are collapsed and permanently, and there is already fibrotic changes. And if if the patient if received hyper means what is the high pressure at tidal volumes, and the barotrauma will be on the opposite side, because the lesion side there's already developed fibrotic changes, and it's resistant to the high pressure. They will not expand with even the high pressure, but the opposite side, it's a hypoplastic lung, and the alveoli definitely they are thin, very fragile, and there is risk that the opposite side it can get the barotrauma, and that side developed pneumothorax. If there is in pneumothorax during CDH, CDH, this 99% on the opposite sides. You have to manage the opposite side to put cannula intercostal or management, or maybe you can put the chest drain. This is the reason.
Jamil, I tell you again the same thing. Please, this is important for you. In 4 to 5 minutes, you don't need to speak out anything extra. Till the time they don't ask you, no need to tell. Okay. Your topic will be, because even in this topic, they will be asking you so many things. So that's this thing. Only tell if they are asking you. Okay. Because otherwise they can maybe your main questions will be missed. Okay. So because there is another important.
The summary is, so healthier side will be at risk of pneumothorax, right?
Yes. Yes.
Okay, so post-op, what is the problem? That sometimes they are not able to close the abdomen.
Yes, so they need to secondary closure.
They may
And
need,
patient
they call as silu. Okay, or if, for example, they closed it. Okay, so then there will be the chances of, what is the word? Abdominal compartment
syndrome.
Okay. So then they will ask you, what is abdominal compartment syndrome?
Increase of intra-abdominal pressure more than 20 is described as intra-abdominal syndrome.
Jamil,
sorry.
this is this answer is not acceptable by you. Okay.
No, if sorry, I know actually follow your instruction that just give the answer what
no,
is
no. It doesn't mean It doesn't mean, because this is a intra-abdominal a high intra-abdominal pressure. This is not abdominal compartment syndrome. Just correct the
increase
definition.
of abdominal pressure
No,
more
sir.
than 20 millimeter of
Just a
mercury.
second, let him speak. Let him speak. Zishan.
Sorry.
Please speak. Finish, Zishan. Jamil, finish.
Yes, sir. Increase of increase of intra-abdominal pressure more than 20 millimeter mercury is called as intra-abdominal sorry, I a little bit
He was
confused.
right. Intra-abdominal hypertension starts at 12 millimeter of mercury.
Yeah.
And pressure above 12 is intra-abdominal
Yeah, the reason is
hypertension. Above 20, it's compartment syndrome.
Listen. What did I ask? I did not ask about
he's right.
intra-abdominal.
Yeah, he didn't ask about the digits. He asked about the proper sentence.
No.
That
Just
I
a second.
spoke, huh?
Jamil, please. Jamil, please. You are also listen. I asked, what is abdominal compartment syndrome? I did not even use the word intra-abdominal hypertension. Okay, because intra-abdominal hypertension is not
Compartment
not
syndrome. Yeah, definitely there's a
compartment
difference in the
syndrome.
pressure. Yeah,
Increase
pressure.
intra-abdominal pressure with development of
organ dysfunction.
Organ dysfunction. Yeah.
New organ dysfunction.
Yeah, this was the complete sentence actually.
Okay, so if they are asking you abdominal compartment syndrome, you don't need to waste so much time. What is the important thing? It is increase intra-abdominal pressure with development of with new organ dysfunction. If it was there before, you will not label it as abdominal compartment syndrome. Okay, that is only, you can say, hypertension. Okay, so because I again tell you something, your answer is not wrong, and most of the people don't fail on wrong answers. They are failed because they are not able to defend their answers, or they are telling too much. You understand? So this is the answer they will be asking you, that patient might need to, when they are closing it, they are expecting in post-operative period, they are expecting this thing. And again, because usually, even if you are keeping patient ventilated, you need to have pressure control ventilation. Okay. Otherwise, if the patient is optimized, you might extubate the patient if the extubation conditions are fulfilled. You will not say that I will extubate. Definitely, because tracheoesophageal fistula is something else. Tracheoesophageal fistula, usually lungs are infected, but there is no problem in the development of the lungs usually. But in congenital diaphragmatic hernia, actually lung dysplasias are there, because what you said, bronchopulmonary dysplasia. Okay, because there is because of the pressure of the abdominal contents in the lungs, alveoli does not get matured. So a little bit difference in the pathology of tracheoesophageal fistula versus congenital diaphragmatic hernia. Okay. So now I think if anything missed, we can discuss. Now the topic of Zishan's interest, cleft palate and cleft lip. So now Zishan will explain. Zishan, you cannot forget this, am I right?
Yes, sir.
So what are the problems in it?
Sir, problems with start with the airway, then associated cardiac anomalies, induction of the patient. Then intraoperative is almost
you know, for example, if I give you a scenario that a baby is going for cleft palate or cleft lip surgery, what are the anesthesia considerations? So use the same word which I have told you, the altered physiological, anatomical, and physiological changes, warranting and anticipated difficult airway, which will be increased in this patient because of cleft palate and cleft lip. We are not able to do the mask ventilation. Back mask ventilation is problematic. Okay, and you might face problem in laryngoscopy. Okay, laryngoscopy, and again this patient might have increased risk of infections. Okay.
Yes, and sorry, just one. And this patient mostly have so associated other anomalies like Tricher,
Pierre-Robin,
Pierre-Robin and Tricher Collin syndromes. Most of they have the association with this cleft. Sometimes it might be isolated cleft palate or cleft or and lip, yes, lip or cleft palate, soft palate or hard palate. But sometimes, you know, it's depends upon there is also classification of these all things. But we have to also preoperatively rule out the severity of this defect and association with other anomalies.
Yes. Okay. So actually, I always forget the anomalies in Pierre Robinson and Treacher Collin. But please, you don't need to read everything, but at least you should be, because as a part of difficult airway management in pediatrics, or generally, you should be knowing what are the findings in this thing. This can come in MCQ as well for the people who are appearing in the MCQ exam, and the people who are appearing in some part of in Saudi Arabia. This is the most commonly asked question in the consultant evaluation exam. They always ask this question. Okay, so you will be expecting difficult intubation, difficult mask ventilation, and you will be ready for all the anticipated thing. Glidoscope is a good option if you have the facility. Glidoscope or video laryngoscope will help assist in the intubation. What about RSI? Would you like to do RSI versus spontaneous ventilation? It is better to have spontaneous ventilation because in rapid sequence induction, in this case, if you try to ventilate, you cannot ventilate. Okay, so awake fiber optic. Okay, like awake, not really awake. Fiber optic may be needed.
Sleep fiber optic in pediatrics with sevoflurane is a good option.
Okay. Okay, Zishan. So now you understand what was the problem in your answer.
Yes, sir.
Before. So that the problem is that even if you have, I tell you, nobody the experience, if you have made a good position, usually we don't face the problem in laryngoscopy. So even in these patients, but the problem is that exam you cannot say this thing. Okay, even if you are in practically what we do, even if you are facing problem, we put the mask and then we put the flush. Okay, press the flush. So even in these patients you will be able to ventilate, but you cannot say this thing in exam, because if you are doing the rescue things, you are inflating the stomach, and then all the problems associated problems will come into the picture. Okay. In addition to the things which we have discussed in this case, the concerns related to throat pack,
Yes,
okay,
because the
concern related to shared airway,
and laryngoscope can during intubation, laryngoscope can fall into the cleft. So
yes,
sometimes we need to
damage,
place, because yes, it
damage
can
to
damage and pack that
into
gap or
structures.
cleft,
Yes, you have to put a pack overall.
attempting the laryngoscope.
Yes, okay.
Yes. And third one,
So
we have to choose the endotracheal tube because they also put this gag. What do you say? That's the plastic surgeons. He will to just keep the mouth opening. Gap clamp.
Boyle Davis mouth gag.
Mouth gag. Sorry, yeah, mouth gag, and it can compress our ETT. Or we use if right our tube, or ideally is reinforced tube.
Yeah, always you can use these things. You can use the word of this north tube, okay, north facing tube, or this reinforced tube, okay. So whenever in airway surgeries related to airway, you have to think about throat pack, shared airway, dislodgement of tube, okay,
Compression of the tube.
compression of the tube, because the same things will be there in, for example, tonsillectomy. Same things, believe me, nothing different, only because sometimes they have adenoids as well. So what will be the problem in adenoids? Again, we might face problem in mask ventilation, because adenoids will cause the nasal obstruction and there is enlarged tongue. So you can have airway obstruction. Okay. Now, so now we will go to this adeno tonsillectomy. This is very important question asked frequently. The main concerns, because we have made our base. So in addition to these things, throat pack problem, shared airway problem, bleeding problem, the problem here will be another thing is the assessment of, if the patient bleeds, assessment of dehydration. Okay. Then there will be second anesthesia. Okay, second anesthesia, there may be residual effect. Patient will be considered as full stomach. Okay, and difficult to assess the bleeding. Okay, so because of airway edema, you might need to have decreased size of endotracheal tube. Okay, then assessment of dehydration is very important, and you will just again label it as 0 to 5 or 5 to 10 or more than 10, according to the parameters we discussed in the morning: mucous membrane, fontanelle, urine output, or according to the age, because usually if it is slightly elder age, the fontanelle will be closed already. So you will be telling about mucous membrane, heart rate. Okay. Okay. And you are expecting to have aspiration. So this is the important thing. And another few concerns about tonsillectomy, they can ask you about the arterial supply of tonsils. I don't remember.
We are talking
Read about it.
post tonsillectomy bleeding, yeah.
Yes, they can ask you about the arterial supply of the tonsils. You can read about it. I don't remember the arterial name, but you should be knowing it. Then they can ask about the technique, hot versus cold technique, because as much as they use cautery, there is more chances of pain and there is more chances of
post-operative
bleeding. Okay, because there may be problem with the clot dislodgement and there can be bleeding. So cold technique, they just crush the tonsil from its bud. Okay, and actually usually there is combination. They use sutures, they use cautery, okay, and they crush as well. Okay, so in this all cases, anything surgery related to Airway, these again, I will repeat, shared airway, tube dislodgement. Okay, shared airway, tube dislodgement, damage to the structures. Okay, so you should be very careful, and proper fixation is important. And you can comment about the specific type of endotracheal tube as well. Okay,
And
so these are,
sometimes they like to listen that there should be 2 suction machines in case of one block, during the intubation. You can use the second one also.
section important, is very
2
important.
sections,
Okay,
yes. Yeah.
section and assessment of the bleeding. Now this question related to Jamil. Jamil will be very happy to answer this, because you remember FCI Viva, blood volume in babies. Okay,
Yes.
you will not
It's
forget it.
in premature, it's 100 to 105 ml per kg. In term new
Leave it, leave it. We discussed in the
sorry.
morning, so I will
Okay.
just try to jump it. We discuss about the fluid
You
management.
just need to remind the things, huh?
Yes, I remind,
Okay,
because
sir.
I cannot forget the questions on which I fail. So you cannot forget the question you fail, and Zishan also will never forget the question in which he failed. Am I right?
Definitely.
And I don't want Memuna to fail and remember like we are remembering. Okay, Memuna?
Oh, God forbidden, inshallah, everyone will pass.
Inshallah.
Inshallah.
I will now, just to relax the nerves, I will tell you something. There was one of the doctor with us. Her name was Sarah. She is from Karachi. So she had the sound coming from her mic similar to you. So I advised her that as soon as you pass the exam, go with your brother or your husband straight away to buy a new mobile. Okay, so that this voice distortion finishes. Okay.
Okay, sir. Thank you.
Okay, so few things are, because actually we are just trying to have a quick review. So maybe I am rushing through the topics, but actually if you just think about it now, I will just show you that what we have covered is a lot of things. I will just a second. This we have already done. Okay, so we have discussed about PEDS physiology, fluid management, PEDS resuscitation, some aspects of the, like I will ask you, what is the most common arrhythmia in pediatrics?
Tachycardia. Sinus tachycardia.
Sinus tachycardia, okay. And SVT is more common, because in adult population, atrial fibrillation, and it can occur in pediatrics as well, but usually sinus tachycardia or SVT is more common in pediatric age group. Am I right?
Right.
And then you can you can review some of the differences of the ACLS and PALS. Okay. Because it will not be possible to cover here, but I'm just telling you that what you should be knowing. We discuss about TOF, we discuss about congenital diaphragmatic hernia, we discuss about Down syndrome, pediatric sepsis. Is there any specific difference in the management in pediatric sepsis? Anyone knows about it? Because I cannot recall. I think
Yeah, the antibiotic is the first priority. Then we give the same, like a bolus of crystallite in sepsis.
so there is no difference then. Antibiotic is there in the adults as well. So there is no difference. Okay. Okay. Prematurity.
Pyloric stenosis is left.
Yes, pyloric stenosis, actually we discussed about in the morning. If someone has missed it, I will suggest to listen together, so that the things which we have discussed in this hour, this cycle of our revision. So actually one thing I missed to tell is in that pyloric stenosis patient, you have to use the word of 4 quadrant suctioning, and you again you have to consider between inhalational induction versus rapid sequence induction. Okay, because there are problems associated with both of them. Okay,
In
but
pyloric
usually,
stenosis?
yes.
Yeah.
RSI, isn't RSI preferred in pyloric stenosis?
Again, thing is that RSI you can say in any patient, and you can have problem because you are saying in the start that you can have difficulty in intubation. Okay, so is it safe answer to use RSI in a patient in which you have difficult airway? You can have problem in ventilation. You can have, so you will say that RSI is always a tricky subject if you are labeling a patient as a difficult airway. So all the babies are anticipated difficult airway. You understand my point? You can do rapid sequence induction, but you tell the examiner, or you make sure the examiner is knowing at it that you are not using the closed-ended sentences. Okay. So let me see what thing we have missed. Stridor we discussed in the morning. Cerebral palsy we discussed. Peds analgesia. What are the things which are different from adults? But that one of them that you are trying to avoid long-acting agents like morphine because it can cause delayed respiratory depression. Other than that, I don't think so. There is any specific NSAIDs. Yes, you tend to avoid in younger population, but it's not contraindicated. Okay, paracetamol is the same. Opioids are the same almost, except for morphine. And yes, liver metabolism is a little impaired, so you will be trying to use medications which have less metabolism and less dependent on excretion through the kidneys. Otherwise, you can use dexmedetomidine, you can use paracetamol, you can use analgesia with lidocaine, and ketamine, even low dose ketamine infusions, and the blocks. You can almost use all the blocks which we discuss. Of course, expertise will be needed. The common blocks will be, and the most important things in when you are telling about the peds analgesia and specifically the blocks, you have to calculate the safe dose. Because, for example, if you have a baby of 3 kg, it's a difficult thing to calculate the doses. Am I right? Because you need to get a balance between the toxic dose and the because concentration usually needed for post-operative pain is not more than 0.1. Okay, even you can further you can give 0.0625 as well, but usually analgesia is achieved by 0.1%. But again, you have to tell that I will be, because the weight is very low, so you have to calculate the safe doses. Am I right? So this you have to tell. Anesthesia for circumcision, caudal block, penile block. Yes, actually this ruptured there are for certain emergencies like twisted testicular torsion. Okay, then obstructed inguinal hernia, intestinal obstruction in the form of intussusception. So these are the concerns are the common, which is electrolyte imbalance, dehydration. So we have discussed in details. Okay, and whenever you are having the ventilation in such patients, you see that you have to avoid the barotrauma, and you have to calculate the dehydration, and you have to anticipate because you have to carefully assess the bleeding. This is the most important thing, because maybe 100 ml in adult is not a big deal, but 100 ml is a big deal in kids. Am I right? So you have to carefully assess the level of bleeding. So this is okay.
Sir, have you discussed about this penile block for circumcision? If not, I can summarize. I explain in 2-3 sentences.
Yes, please.
You already discussed
1 minute only.
Okay. Actually, the first of all, we see the nerve supply of the penis. Then the distal 2/3 is supplied by pudendal nerve block. Pudendal nerve, and the base of the penis and lateral side is supplied by the genitofemoral and ilioinguinal. The dose calculation is 1 ml plus 0.1 ml per kg. bupivacaine 0.5%, or we can use 2% lidocaine. If we give the block on the
Just a
base of the
second,
penis.
Jamil. You are talking
Sorry.
about post-op analgesia. So why you want to give 0.5%?
No.
No
I
need.
am telling for circumcision.
Circumcision. Even then,
Yes.
you cannot. Okay, fine. But you don't need.
For circumcision, yes, we can give 0.5 or 2% lidocaine. And
Okay.
it's 1 ml plus 0.1 ml per kg is the simple formula. And we give both sides of the base of the penis because there is
Sorry,
brocas.
Jamil. I will have to
sorry.
interrupt you. Will have to interrupt you because this answer, I don't know from where you are following it. But thing is that, would you like to perform the surgery in penile block? No. Okay. Usually you need to give because it will, if they are asking you this question, usually you have to, at least you have to tell about the weight. Will you be using 0.5% in every patient? If you have a newborn 3 kg, how will you calculate it? Yes, Jamil. Jamil, can you hear?
Sorry, my mic was muted. Actually, if the, for example, if it's 5 ml, then 1 ml plus 0.5 ml. It may be 1.5 ml total dose for
No,
that child.
No, just a second. I give you a
Yes.
scenario. You have a 3
Okay,
kg.
sir.
You have a 3 kg baby.
Yes.
Okay.
Then we can give 1.3 ml total.
Just a second. To start with, what is the safe dose in this baby? Bupivacaine.
6 milligram.
Bupivacaine is 2 milligram per kg.
So it is 6 milligram. Okay. So
Yes.
if you are giving 0.5%, 1 ml, it is 5 milligram.
Yes, sir.
So can you add 2% by lidocaine?
No.
sir.
I'm not telling about the lidocaine. I can carry the volume. 1 ml plus 0.1 ml per kg additional weight of any baby, above
Sorry. Maybe I'm
for
not
any
able
baby.
to understand, Jamil, but I think this is not an appropriate. Please don't use it. This is not
Yeah,
appropriate.
actually it's written in Julian Barker. It's like
Forget about it.
formula.
Forget
Okay, sir.
about it. Forget about it. This is you know,
But the
try
proper,
to say.
yeah, I understood proper. If we calculate the safe dose and according to
Do
that we
it.
can
So this is the
it's the
better
more safe
answer.
answer.
So this
Yeah.
the better answer. You will calculate the safe dose, okay, and you will see the scenario whether you are giving. Of course, usually they are being done in some sedation. Am I right? So you are giving it for analgesia, okay? Because the way we do by holding the baby is not the correct way, okay? So penile block you are
Yes.
giving for analgesia. So for analgesia, the dose is a little bit different. Am I right?
Yes, even the concentration is you can give the
You don't need 0.5%. Okay.
Yeah.
You don't need
0.25 is okay.
0.5%.
Yes. 0.1
0.1.
ropivacaine.
Yes, 0.1. Remember one thing, Jamil, specifically, this is message for you because Pakistani exams are a little different than international exams. Ropivacaine, till the time they are not asking you, no need to use ropivacaine. Please. You are in Pakistan, 90% of people not even have seen ropivacaine. So no need for you to tell about ropivacaine. Okay. Try to concentrate on the place where you are speaking. Okay. So it is better to be on safe side. You calculate the safe dose, and then you will be thinking whether it is for surgical anesthesia or for analgesia. If you are giving analgesia, you 0.1% or maximum 0.2% is enough. Okay. You don't need to go back further. Then you can decide the volume accordingly. Usually you need 2 to 3 ml. Am I right?
Yes.
2 to 3 ml of volume.
Volume we can, yes, then the dilute,
Adjust the dose. Okay. So I hope it is clear to everyone.
So it is 0.1 ml per kg or 0.1%. Is it
Okay.
like this?
No, no.
No, that is for
No,
Arbitrage regime.
Don't mix it with the 0.1 ml per kg. Just
If we have
calculate the
now,
safe dose according to the weight. This is the recommendation from Dr. John. It's more proper,
Actually, it
the
is
answer.
easier for you. It is easier for you to defend. Okay. Okay, Mamuna. Because
okay.
the thing is that in the exam, you don't need to reproduce a book. You just need to show the examiner that you are safe.
Okay.
Okay. So actually, we have discussed a number of things. So in due course of time, if I have missed anything, I will try to have another session. But tomorrow, I am thinking of doing liver. Okay, as a quick review of liver for anesthetist. Okay, so thank you very much. And anyone wants to ask any question, all of you are welcome. Okay, thank you very much.
Thank you, sir.